Hi group, and welcome to Unit 18, where we're going to talk about serology. We're going to talk a little bit about the disease infectious mononucleosis and how we test for it. We're going to talk about streptococcal serologies and how we test for those. And finally, we're going to talk about HCG testing, which is usually the testing we use for pregnancies, but it can also be used to look for malignant tumors. So stay tuned for more of Unit 18. So the Epstein-Barr virus is what causes infectious mononucleosis, and that Epstein-Barr virus was first discovered in 1964, but it wasn't really associated with mononucleosis until 1968. Infectious mononucleosis is an acute viral illness, and it is caused by the Epstein-Barr virus. It is a human herpes DNA virus which infects the B cells. Okay, some symptoms of infectious mononucleosis would be sore throat, fever, fatigue, increased white blood cell count, enlarged lymph nodes, and about 50% of the time people get splenomegaly, which is a very large, fragile spleen. It's kind of one reason why people that have mononucleosis cannot play contact sports for at least a year, because their spleen is so fragile. The illness is benign and self-limiting, okay, but the convalescent stage can last for months to a year. Okay. Infectious mononucleosis is affectionately called the kissing disease because it is spread through saliva. It is transmitted primarily by close contact with infected oral secretions, and it's usually young adults that experience infectious mononucleosis. The incubation period can range anywhere between 10 and 50 days, and usually the acute disease lasts for about 4 weeks. But like I said in the previous slide, the convalescent stage can last months to years. Okay? You may have heard of other Epstein-Barr virus-related illnesses as well. The first one I want to mention is called Burkitt's lymphoma, and this is basically a form of non-Hodgkin's lymphoma where you see cancer in the B cells. There's approximately 12,000 cases a year in the United States. We also have another disease caused by the Epstein-Barr virus, which is called nasopharyngeal carcinoma, which is an epithelial type of cancer. This is cancer in the upper nose and throat. It's kind of rare and difficult to diagnose early. And then Epstein-Barr virus can also cause B-cell lymphomas and chronic fatigue syndrome. One of the best and quickest way to diagnose infectious mononucleosis is by doing the heterophile antibody tests. A heterophile antibody is an antibody that reacts with an antigen entirely different from the antigen that caused its production. Okay? And we're going to do the heterophile antibody test in lab. Also, we can look for the antibody anti-VCA IgM. Those levels are going to be increased in patients that have infectious mononucleosis, and that VCA stands for viral caspid antigen. The liver enzymes are also increased. That would include alpha phosphatase, ACT, and GGT. The leukocyte differential, you're going to see increased atypical lymphocytes, and that's kind of the clinical picture for infectious mononucleosis. In the heterophile antibody test, we're looking for 3 different types of antibodies: the Forsman antibody, the serum sickness antibody, and the infectious mononucleosis antibody. Now, the Forsman antibody, everybody has that. That is found in normal people. The serum sickness antibodies are found in people who are allergic to horse serum vaccines, and the infectious mononucleosis antibody are seen in people that have infectious mononucleosis. Now, these heterophile antibodies react with other naturally occurring antigens on the cells of either sheep or horse red cells. And when we do the heterophile antibody kit, we're actually testing patient's serum against sheep or horse red blood cells. This heterophile antibody test is considered a direct hemagglutination procedure because in the heterophile antibody test, our patient's serum is reacting with naturally occurring antigens that are either on sheep or horse red blood cells. The heterophile tests have been used for decades, but the rapid tests of today are based on a couple more complex tests called the Paul-Banel test and the Davidson test, and we're going to talk about those in upcoming slides. Now, the Paul-Banel test indicates if the heterophile antibody is present in patient's serum, but it doesn't tell you which type. The Davidson test indicates which type of heterophile antibody test is present. So mainly we are concerned with the infectious mononucleosis antibodies. So let's go ahead and talk about the Paul-Banel test and the Davidson differential test. So the Paul-Banel screening test tells us if we have heterophile antibodies, but it doesn't tell us which type. This is usually a screening test for the presence of heterophile antibodies. One nice thing about the Paul-Banel test is that it's simple and inexpensive. This is a hemagglutination test designed to detect heterophile antibodies in patient serum when mixed with antigen-bearing sheep erythrocytes. We can take dilutions of inactivated serum and mix them with sheep erythrocytes, incubate it, centrifuge it, and then macroscopically look for agglutination. A high amount of anti-sheep agglutinins in patient serum indicates a disease associated with heterophile antibodies. This is just a preliminary test. In the Paul-Banel test, we're going to make several serial dilutions of the patient's serum. And when I talk about the serum being inactivated, what I'm talking about is that complement has actually been inactivated. Okay? We're going to use a sheep cell suspension and we're going to add it to each dilution. Then we're going to incubate those tubes for 1 hour at 37 degrees Celsius. The tubes are then viewed for agglutination. We look for agglutination, and the last tube that agglutinates is your titer. So our normal titer is less than 56. We always report the reciprocal of the titer. So if a titer is 1 to 56, we would report the reciprocal, which would be 56. Any titer above 56 means that heterophile antibodies are present, but it's not going to tell us which type of heterophile antibody is present. The Davidson differential test tells us the type of heterophile antibody a patient has by removing the cross-reacting serum sickness antibody and Forsman antibody. In the Davidson differential test, we are looking at a procedure that distinguishes between the heterophile antibodies that agglutinate the antigen-bearing erythrocytes of sheep. The differential nature of this test is predicated on the fact that sheep and beef erythrocytes bear some common antigens not present on kidney cells of the guinea pig. Exposure of patient serum to guinea pig cells, which are rich in Forsman antigen, and beef erythrocytes, which are poor in Forsman antigen, produces differential absorption. So I'm going to show you a chart in upcoming slides here that shows which antibodies are absorbed and removed by centrifugation and which are left over, indicating that an infectious mononucleosis heterophile antibody is present. In the Davidson test, we're going to take guinea pig kidney and combine that with patient serum, and the guinea pig kidney antigen is used to remove, and it's actually absorbing the serum sickness and Forsman heterophile antibodies. Then what we do is we add sheep cells. No agglutination occurs because the sheep cells will not bind to serum sickness or Forsman antibodies as they've been absorbed by the guinea pig antigen. Beef red cells are then combined with the mixture above, and the beef red cells are used to absorb serum sickness antibodies and infectious mononucleosis antibodies. Sheep cells are then added to these human serum dilutions and guinea pig cells and beef red cells. Sheep cells will at this point also agglutinate with Forsman antibody that was not previously absorbed by beef cell antigen. This is a double indicator system, meaning that there are 2 stages. Stage 1 includes guinea pig kidney in patient serum and sheep cells, and stage 2 includes beef cell antigen, patient serum, and sheep cells. Using both stages in this test helps us determine if our patient has the infectious mononucleosis heterophile antibody. So let me show you on a chart kind of what's happening with this system. If you take a look at this chart very carefully, you can see that guinea pig kidney absorbs serum sickness and Forsman antibody. Beef cell absorbs infectious mononucleosis and serum sickness antibody. This combination determines the kind of heterophile antibody a patient has. Let's take a look at streptococcus serology. Streptococcal infections and serological testing is what I'm going to cover on this slide. Now, we all know that Streptococcus pyogenes causes the majority of strep infections. Okay? Other less serious strep A infections would include things like scarlet fever and impetigo. Now, Streptococcus group A is the most frequent cause of acute pharyngitis in kids 5 to 15 years old. That's basically strep throat. Now, Streptococcus pyogenes can also cause cutaneous infections in the very young. A cutaneous infection would be something like impetigo. Usually, pharyngitis and pyoderma resolves quickly with a shot of antibiotics, but occasionally they can lead to serious complications. And of course, those complications can be acute glomerulonephritis or rheumatic fever. Now, there are several virulence factors and toxins and enzymes associated with the streptococcal organism. Strep A actually produces upwards of 20 antigenic substances, producing a number of different antibodies. So some serious consequences of an inadequately treated strep A infection would include rheumatic fever and streptococcal glomerulonephritis. In rheumatic fever, the clinical presentation would be lesions of the heart muscle, heart valve damage, lesions of the joints, and central nervous system depression, including paralysis. In streptococcal glomerulonephritis, what you're going to see is an inflamed renal glomerulus. The glomerulus is the top portion of the nephron of the kidney that does all the filtering of the blood. Urine is basically just super filtered plasma is all it is, okay? Also in streptococcal glomerulonephritis, you're going to see hematuria, that's red cells in the urine, proteinuria, which is protein in the urine, edema, which is swelling, and also hypertension. So that's kind of the clinical picture of the streptococcal glomerulonephritis. Like I said, strep A produces upwards of 20 antigenic substances, producing a number of different antibodies, and we can actually see those antibodies in patient serum. Okay? Diagnostically, the most important antibody is called anti-streptolysin O. We also can abbreviate that as ASO, and it's elevated in 80% of people that have rheumatic fever, and it's an excellent test to diagnose streptococcus-associated disease. Some of strep's important antigens would be streptokinase, streptolysin O, streptodornase, hyaluronidase, and NADase. The corresponding human antibodies that we're going to look for in patient serum would be anti-streptokinase, anti-streptolysin O, anti-streptodornase, anti-hyaluronidase, and anti-NADase. There's a couple of different serology kits on the market that will look for streptococcal antibodies. Okay, one is a passive agglutination test called the ASO latex test, also known as the Immunolex ASO. And another type of kit test that we can look for streptococcal antibodies is a passive hemagglutination test called the streptozyme test. In the passive agglutination test, we're going to take our latex that comes with the kit and we're going to resuspend that latex. We're going to add 50 microliters of patient serum to a test card and then a drop of the latex, and then we're going to mix that together with the stick. We're going to mechanically rotate it on a rotator for 2 minutes at 100 RPMs, and then we're going to report agglutination as 0, 1 plus, 2 plus, or 3 plus. Of course, a 0 reaction is going to be where the background is very smooth, and a 3 plus reaction is where the background is clear, but you have several large agglutinins. This is a semi-quantitative procedure where you can kind of tell how much antibody concentration is in the patient's serum. Okay, now the passive agglutination for ASO test only quantitates the presence of one antibody, and that antibody is called anti-streptolysin O. The streptozyme test, on the other hand, looks for 5 different antibodies. This is a passive hemagglutination test where we dilute the patient's serum 1 to 100 with saline. So essentially we're taking 9.9 mils of saline and we're adding 100 microliters of serum. Once we dilute up our patient's serum, we can actually place 50 microliters of that diluted sample and 50 microliters of sheep red cells sensitized with 5 antigens on a test card and mix it together. We want to very, very slowly mix that test card by hand for about 8 to 10 RPMs for 2 minutes. That's really slow. And then we report either positive or negative. And this is qualitative. So a positive result would show the presence of large agglutinins, and a negative control would show a completely smooth background. Okay? Now in the streptozyme test, we're actually looking for 5 different antibodies. We're looking for anti-streptokinase, anti-streptolysin O, anti-streptodornase, anti-hyaluronidase, and anti-NADase. Now, the streptozyme and the ASO tests have been based on an old school type of test called the ASO tube titer. Even today, old doctors will want to order an ASO tube titer test, but that's really no longer the gold standard. The gold standard, on the other hand, for serological testing for streptococcus would be streptozyme and ASO test. Okay? In the old school ASO tube titer test, what we would do is make serial dilution of patient's serum, buffer, and streptolysin. So we're going to use several tubes to make a concentration of 12 up to 2500, or a titer of 12 up to 2500. We incubate these tubes for 15 minutes at 35 degrees, and then we add a suspension of human red cells to each tube. Those are going to be O cells because they don't have any antigens on them. Okay, we're going to incubate for 45 minutes, centrifuge those tubes for 1 minute at 1000 to 1500 RPMs, and then we report the highest titer with no visible hemolysis. This method is different than hemagglutination. This instead is called hemolysis and neutralization. Okay? The principle is that we have streptolysin S and O, which are going to lyse the human red cells that have been added to the tubes as the indicator system. These are not the patient's cells, but random type O human red cells. If anti-streptolysin S or O are in the patient's serum, the donor cells are going to be lysed. The last detectable hemolysis seen is your endpoint titer, whatever that may be. There's other methods that we can use to look for streptococcal antigens, or antibodies. In the direct ELISA test, we're actually looking for the antigens that are ripped off the strep A organism. Okay, that's when they do the rapid strep kits at the doctor's office. That's called a direct ELISA test. We can also do DNA probes. Okay, and there's several different types of DNA probes, including hologic gen probe out of San Diego, California. Let's go ahead and talk about HCG. Human chorionic gonadotropin is a hormone that doubles every 2 to 3 days and up to 8 to 10 weeks of gestation. Then that hormone starts to drop off. There's actually two types of HCG. One is called alpha HCG and one is called beta HCG. We're always going to look for beta HCG for pregnancies and tumor indicators. Alpha HCG is similar to other hormones, and that's why we don't look for alpha HCG. Instead, we look for beta HCG, which is very unique and easy to evaluate, and it's very different than other hormones. Okay? An ectopic protein sensitivity as a tumor marker or indicator of pregnancy is what HCG is used for. Okay, if you have a serum level of HCG that is greater than 1 nanogram per mil, it usually is strongly suggestive of pregnancy or a malignant tumor. So even men can have a positive HCG if they have a tumor. Okay, generally we use HCG to look for pregnancies, but again, HCG in men will increase if our patient has a malignant tumor. Okay. A hormone that is used to evaluate other carcinomas or malignancies, such as hydidiform moles, which is a tumor that has originated from the placenta, choricocarcinoma, which is a type of uterine cancer. We can use HCG to diagnose testicular malignancies, or oat cell tumors of the lung. This is also known as small cell lung cancer. And HCG can also indicate if our patient has ovarian cysts. We can test both urine and serum for this type of test, and there are qualitative and quantitative assays available. Usually what's performed in the hospital laboratory is a qualitative urine HCG or a qualitative serum HCG, and most of the time that's for pregnancy diagnosis. HCG levels will go up in pregnancy anywhere between levels of 25 and 100,000 international units per liter, okay? And these values double exponentially all the way up into the 10th week of pregnancy, and then it starts to decline. So we see very high numbers of HCG levels in people that have a normal pregnancy. If you have low levels of HCG, like 150 to 880 international units per liter, this usually indicates an ectopic pregnancy or a tubular pregnancy, one that's developed in the fallopian tubes. That's very dangerous, and the doctor needs to know that. Very, very high levels of HCG indicate malignancies, and the levels drop off significantly once that tumor is removed or that person is treated for that tumor. There's a couple of different ways that we can detect HCG. One is called agglutination inhibition. It's exactly like it sounds like. We have antigen, which is HCG, and antibody, which is anti-HCG, and latex particles with HCG antigen added. If the urine contains HCG, the HCG is going to react with anti-HCG, thus preventing the anti-HCG from agglutination with the latex and HCG. If urine does not contain HCG, then the anti-HCG will agglutinate with the latex. That's called agglutination inhibition. Okay? Passive hemagglutination is where we have an antigen such as HCG and an antibody, which is rabbit anti-HCG, sheep red cells with HCG as well. Instead of latex, the particulate that we normally use, we're instead using a cell. So this is why it's called hemagglutination. And then finally, the most common way to detect HCG is by a direct ELISA test. This, of course, stands for enzyme-linked immunosorbent assay. The HCG in urine reacts with an anti-HCG in a cellulose membrane of a test cassette, plus the specimen reacts with anti-HCG in conjugate, causing a colored line. So like I said, the most common way to evaluate HCG is by doing a direct ELISA test. This is a kit test that uses either urine or serum. Okay, we're looking for HCG in the patient's urine or serum. The test uses a combination of antibodies, including a monoclonal HCG antibody, to selectively detect elevated of HCG. The assay is conducted by adding urine or serum specimen to the specimen well of the test device and observing for the formation of colored lines. This is very similar to similar technology to the strep throat streptococcus antigen kit. Okay. In this HCG method, we are looking for the urine or serum to migrate up the cellulose acetate paper along the membrane and react with a colored conjugate. Positive reactions usually show two colored lines, and negative reactions usually show one colored line, because one colored line is always considered the control. An absence of any colored line suggests an invalid result. Okay, so that's a little bit about infectious mononucleosis, streptococcal serology, and finally HCG. Okay, direct ELISA for HCG testing. This is pretty much the type of testing that we do in the laboratory. Here we have the test cassettes that you can see over there on the right. And what we'll do is we'll take 3 drops of urine and put it into the test well, or the sample well of the cassette. We're going to set a timer for 3 minutes, and what's going to happen is that urine is going to migrate up the cellulose acetate paper away from the sample well. We're going to look for colored lines because the antibody and the conjugate have linked up. 2 colored lines means you have a positive test for HCG. 1 colored line means you have a negative test for HCG. And if you have no colored lines at all, it indicates an invalid test. All right, so that's strep, HCG, and infectious mononucleosis in a nutshell. Stay tuned for Unit 22.